thank you all for coming this evening. Really, I admire you for spending part of your evening in the middle of the week where there's basketball or football on TV and you come here to listen to a lecture on sinusitis. Some of this material may be basic to many of you. Some of this material may be a little advanced. But I don't intend to make you all sinus experts, but I want you to understand what's available in the treatment of patients that have chronic sinus conditions. I'm going to try not to focus on acute conditions. Now, what happens when you get a bad cold, you develop into a sinus infection? This is more about patients that have lingering sinus problems. Of course, I'll be happy to talk to you about anything else. If I'm able to answer any questions at the end, I'll be happy to do so. Now, sinusitis is one of the most common illnesses that we have in the United States now. Basically, it affects over 37 million Americans each year, and that's a very large number of patients. But how many of patients that have sinusitis actually complain about it? You just live with it. Well, there are a lot of patients that actually come to our office, and it accounts for one of the most common office visits in the United States. 7 million people annually actually have symptoms of sinusitis that seek medical help and require further treatment. Now, the most common symptoms that we have or people are aware of are going to be, of course, the ones listed on the screen. Facial pain, that's very common. Nasal congestion is very, very common in patients that have sinus inflammation. Discharge, usually the discharge is going to be colored, but the fact that you may not have nasal discharge does not mean that you don't have sinusitis. A lot of patients don't have nasal discharge and they still have chronic sinusitis. Dental pain in the acute phase may happen, and fatigue or tiredness or malaise, not just feeling well. It's a very common symptom of any chronic illness, and chronic sinusitis is just another chronic illness. Headaches also is a symptom of sinusitis, but I have to tell you this. Most patients that come to my practice with, quote, sinus headaches don't have sinusitis. So a lot of headaches are believed by patients to be sinusitis because of the location being in the face, but whereas in fact they are not really sinus related. Now, how common is it? Well, it's more prevalent than heart disease or asthma. And it has a very significant impact in the quality of life that patients have. People don't feel well, no different than patients that have asthma or heart failure or back pain. And it accounts, as I mentioned before, for millions of visits each year to a doctor's office. So let me focus a little bit on the anatomy of the sinuses. Sinuses are cavities that we all have around our head. This set are called the frontal or forehead sinuses. The ones in between the eyes are called the ethmoids. The ones in the cheek, right above the teeth, are the maxillary. And then we have a set that is way in the back called the sphenoid. Now, a lot of people don't have the frontal sinuses. Actually, about 1 out of every 10 individuals that walk the street don't have one side, and between 1 in 100 to 150 don't have both sides. So that's one less thing to worry about. But basically, they are cavities that are air-filled. The purpose of the sinuses, they have tiny little hairs that transport mucus, bacteria, and particles to clean the cavities that provide resonance to our voice. All of you might have had a sinus infection, most of you at some point, and then you talk like you are underwater. And that is the reason that we need the sinuses. If we didn't have sinuses, our voice may be a little different than what it really is. So they need to be present and they need to be open, and the sinus windows need to be open for us to be able to have adequate clearance of the sinus cavities. Now, what can we do once we make a diagnosis as clinicians of chronic sinusitis? Of course, antibiotics are very commonly prescribed. How long should you place patients on antibiotics? That's a little bit controversial, but we have a standard. The minimum for chronic sinusitis before we consider other options is going to be 2 to 3 weeks. Some antibiotics also have anti-inflammatory properties, and which antibiotics, of course, is up to the individual clinician, but we have guidelines that we try to follow. Now, nasal steroid sprays have been known as the gold standard. Many of you might have heard, I'm not trying to advocate any specific brand, but might have heard of Flonase. Now there's one over the counter you can buy without a prescription called Nasacort AQ. Those are sprays that basically will help reduce inflammation, and by doing so will promote natural drainage from the sinus windows. We call that the ostia. Decongestants have been advocated also in the management of sinusitis. Antihistamines may be helpful if the patients have allergies, but frequently they make the secretions a little thicker. So many times we don't use them because they actually make things a little bit more stagnant. Steam has been used since the old ages. I feel that that's an effective way to try to reduce some swelling, help clear mucus, and saline drops as well. How many of you have heard of the neti pot? Okay, I think if I ask you that same question 15 years ago, you probably would know what it is. Thank goodness for Dr. Oz. He was on TV, he talked about the neti pot, and of course everybody is now using the neti pot. The neti pot is actually a very effective way to clean out the nasal cavities and reduce bacterial contamination. It is soothing, and it is a passive system, meaning you put it on one side, you wait, and it goes out the same side on the other. There are some systems that you can buy also over the counter that are more active, more like a true sinus rinse. They're actually more effective and have been found to be effective in reducing what we call bacterial biofilm or bacterial contamination. Now, let's show some pictures. You may wonder, what is that? That's not an alien, it's actually a person. But what you can see in there, that's the eyes. We're taking what we call a coronal view. It's like you're slicing from the top to bottom, moving from the front to back. So that's the eyes. You would see those circular structures, and that would be the brain. Sinuses are air-filled cavities. So all these areas that look black, they are normal. Those are the cheek sinuses, that's the ethmoid sinus, and there is a deviated septum. Now, deviated septums, we'll talk a little bit because most people have them. The fact that you have a deviated septum does not mean you need to have surgery, but occasionally patients do if it becomes an impairment on their breathing, ventilation, and sinus function. Now, that also shows the intricate anatomy of the nasal cavity and the sinuses. I don't know if you can see this area, but it's a very tiny funnel called the osteometal unit. The osteometal unit is something that we talk a lot in our specialty because that is the first area to go. When you have inflammation, that gets obstructive and it sets a chain reaction where there is more inflammation, lack of oxygen, bacterial contamination, and infections start usually in that region. So the goal is to keep that area clean. And you can see that in color a little bit better, where you can see that little yellow area. That's the osteometal unit. So that 3 to 5 millimeter area, less than half a centimeter, is the culprit for most problems that we have in the sinuses. Now, showing just some anatomic abnormalities that may not mean anything to you, but you can see a little bubble right there underneath the eye. That's a cell that basically can obstruct the sinus window, and it's not something people develop, it's something you were born with. You see that you don't have that on the other side, but you do here. So we look when we do CAT scans or x-rays for those patients that require them for anatomic changes that may predispose them to have recurrent infections. Now, you're looking at a patient's nose on the right screen, and you can see that big area. That's a polyp that basically is shown here, but behind that actually there's more. That's a benign growth called an osteoma. They grow very slow. That's not necessarily a problem, but when they get that big, they need to be removed. But compare the previous x-rays with this. This is polyp-like membranes that are filling not only the nasal cavity, but the sinuses. See that? So this is an abnormal CAT scan, and that, of course, it's an abnormal finding as well. Now, this is a picture that it's taken in an axial views. Unlike the pictures I showed you before, these are slices that you're taken from the front to bottom. So you can see from the front to the back. The maxillary sinuses are open, but the wall dividing the nose into right and left, it's so obstructive that it actually impinges against that sinus. This is a specific case where a patient complains of congestion or recurrent infections. You probably are going to have to address this at some point in their life surgically for them to get better. And that's also an example of a deviated septum that you can see on the right of the screen. So when we're looking at the gamut of chronic sinusitis patients, there are a lot of them. Many of them seek medical help and improve with medical therapy. For those that don't, there are surgical alternatives. Now, we talked about medical therapies that may include antibiotics, decongestants, the neti pot, steam, but the overall goal is to decrease inflammation and try to relieve obstruction in that tiny, tiny sinus windows. There are, of course, some problems. Some patients are sensitive to medicines. Many patients do not like to use a nasal spray every day for 6 months or for 3 months. They may take other medications that may result in drug interactions, so they're trying to avoid them, or some people just don't like to take medicines. This is an old picture. I just want to share that with you. This patient actually did well, so don't be afraid. They actually did very well, but it's an open surgical procedure. I show that just because it is basically a surgery that I can almost say it's a surgery of the past. When I was in training, and that was many, many years ago, we used to do this at least a couple of times a week in my residency. We'll go behind the cheekbone, you can see the upper teeth, drill a hole, clean the sinuses that way, pack it, we would close, they'll go home the same day or the next day. But this is a very aggressive surgery for problems that no longer require this type of surgery. Now, we still do this, but on a very rare basis for different type of situations. But as a rule, to give you an idea, I used to do this, as I mentioned, a couple of times a week during training. I think the last operation that I did of this type was at least 15 years ago. So there are much better ways to handle that with minimal morbidity, and patients do very, very well. Now, endoscopic sinus surgery, which is using little rods, became popular in the 80s. We learned these technologies from the Germans and actually from the orthopedic surgeons who were doing already endoscopic procedures. And it became known as functional endoscopic sinus surgery because we preserved natural structures, and the surgery was as such considered functional. We use telescope, very similar to that one. And I don't know if you can see, but the tip in here is tilted. That would be a 45-degree telescope, but you could actually put an instrument in somebody's nose and look up through a 45, through a 30, even a 70 or 110-degree telescope. You can actually look back. And this allows us basically to get into the nasal cavity. Just to show you, and I'm not going to talk about it at all, but neurosurgeons now do this type of surgery to access areas of the skull base and bottom part of the brain that were previously not accessible. So skull base surgery is becoming very, very well known, and there are a lot of excellent skull base surgeons here at Florida Hospital as well. This is the anatomy of that unusual cell that I mentioned before, and you can see how it can obstruct the sinus window. This is a patient whose window is completely open, and that patient will probably have much better ventilation. When we talk about surgical procedures, you can see this CAT scan about how this window, it's huge. This is maximally invasive surgery. You have a lot of room. Now you may wonder, if you have that much room, isn't that great? Well, the answer is not necessarily. Patients that have had that much surgery, not uncommonly will develop problems with crusting and actually non-functional cilia. Those tiny hairs that I told you are important to help clear mucus. Now, to show you different approaches on how we do more modern technology, I want to show you two short video clips, 60 seconds each, maybe less, that will show you the difference between endoscopic sinus surgery, which is considered minimally invasive, and a new technique that I'm going to expand on called balloon sinuplasty, which is something that can be done as an outpatient, and patients can return to work many times the next day. So, on the left, you actually see the approach of the minimally invasive but endoscopic approach. So basically, you can see the suction. We're doing surgery here. We're taking those little biters and biting this area called the uncinate process. That's what allows us to enter that sinus window. I mentioned to you there's that one area that it's 5 millimeters in diameter that it's so important. So that's what we do. We get in with telescopes. You know, the assistants can help us and see on the camera what we're doing. And right now we're using a little device that I'd like to commonly call it a Pac-Man. I don't know if you're familiar with that Pac-Man game. It's just like a shaver that goes in and out and bites tissue. So it's now widely open. And that's basically what we do in this setting. Now, we're not doing major invasive surgery. That's still minimally invasive, but compare that with this type of procedure. What we're doing is placing a guide, and through that guide, you can see a balloon is inflating, and it's pushing that area that was previously removed towards us. What it's doing is dilating the sinus window without any tissue removal. There's several studies that have shown that actually this is effective in maintaining that window open in over 90% of the patients, and the studies were done a year later to show that indeed it does work. There is no tissue removal, so the amount of bleeding is either minimal or non-existent, and this can be safely done maintaining function, structure, and yet relieving symptoms. Now, let me show another little clip. I believe this is a testimonial. No. It just shows a pictorial as to how this specific system goes. It's no different from what cardiologists do when they do angioplasties. They go in, put a wire. We can actually see through the bone with a very bright light that we're in the sinus. Then a catheter with a balloon is deployed, goes into the sinus, like you see it there. The catheter will then be inflated, and it's a very strong catheter, to about 12 centimeters of atmospheric pressure. Some patients have this done under local anesthesia, and they'll actually hear a crack or a shift in the bone. Once we've done that, we can put another catheter and irrigate it thoroughly. Now, is this something that you do mainly in adults? Not necessarily. I did this morning 2 children in the operating room here at Florida Hospital, 1 3 and 1 4. This is exactly what we did. Those kids saved, basically were able to save them from having major invasive surgery. They're not going to have any pain more than needing a Tylenol. Okay. So the forehead sinus is very similar. You can see the guide wire going up to that area, put a catheter, which is a different angle. In the past, when these systems first became available in the late 1990s, we used to use fluoroscopy, meaning like an X-ray machine in the room that will allow us to see if the guide wire is there. We no longer use that because we have better techniques that allows us to see an intense light in the sinus cavity. We have to turn the lights down in the room that you're in, but you can see it well and you know that that's where you are. And that again shows inflation of that balloon device. And
how long does that last?
those studies that we've done that showed actually prospective studies in several areas, they're called the CLEAR studies, showed that the windows, when they were studied up to a year later, they were open. Unfortunately, we don't have data that shows much more beyond a year. Part of the reason is patients are lost to follow-up. Yeah. You can see right there how that sinus window is widely open to the forehead region. And that's what we look at when we're seeing a patient under anesthesia, for example. Turn the lights down and you know that's where we are. Of course, we know the landmarks very well, but the transillumination is a guide that allows us to know that we are in the sinus cavity. What are the patient benefits of that? The majority of the patients consider that a very terrible procedure. It can be done under general anesthesia if you prefer to be asleep and you don't want to hear bone crunching, or it can be done under local anesthesia. It actually takes longer to do under local anesthesia because it takes a good 30 minutes to get your nose numb. The procedure itself may take no more than 10 minutes. But again, a statistically significant improvement was noted at 1 year. With traditional sinus surgery, we have to take the patients in the office once a week, usually for a couple of times to do debridements. The number of debridements or cleanings, what we call material that accumulates, crusts that are important to be removed, was reduced. And most patients did very well. It's much more comfortable. We give a patient a little page, which is a questionnaire called the SNOT, appropriately named, Sinonasal Test Outcome Questionnaire, the SNOT 20. They answered 20 questions before and after the procedure. And in our hands, for our group, the success rate has been very, very good as far as seeing how they do before, and then we do that questionnaire 3 months later. Now, this is the testimonial. I borrowed this from the company that makes the sinuplasty.
The minute that I wasn't working out every day of my life, the problems that I had, they started to magnify. Doing some kind of physical activity, became short of breath. If I was at work, broadcasting, I started having severe postnasal drip and taking allergy medicines, nasal pumps. I was trying to rinse my nose. I have a steam shower I was living in, trying to just get as much of it out as I could. Watching the spicy things I ate because I felt like it was affecting my voice, maybe not having caffeine or stuff like that, just trying not to affect my voice. I thought it was, I was trying just about anything, all kind of homeopathic remedies and teas and stuff like that. I tried it all. I literally tried it all. I tried a hyperbaric chamber, felt like, let me see if I can get more oxygen by sleeping in one of these things. None of it worked. And it's crazy that it was such a simple procedure to get done to fix something that I struggled with for a long time. Not a lot of time out, not a lot of recovery time. And when I think about how I feel now and how I'm capable of breathing, it was an easy decision, If I had known about it early, it probably was, and if it was available earlier, probably was something that I would have gotten done a long time ago and not suffered through what I'd suffered through. I tell them that balloon sinuplasty is it's a must.
Thank you. We're fortunate enough to have Florida Hospital assist us in bringing balloon sinuplasty to Central Florida. Actually, East Orlando was the first hospital where balloon sinuplasty was performed in 1997. The technology has changed a lot since then that allows us to do it much safer, much quicker, minimally invasive. So it is something that we are doing because we feel it actually helps the quality of life in a lot of our patients. Now, if you have an individual who has a history of extensive polyps and a lot of growths in the nose that have to mechanically be removed, this may not necessarily be the procedure for you. We still have to remove the polyps and do a traditional endoscopic sinus surgery. But for those that either have small amount of polyps and mainly it's a problem with drainage, or patients that have recurrent acute sinusitis. By that I mean that they have more than 4 infections per year and the CAT scan doesn't show that much abnormal. They also seem to benefit tremendously from this, and they were included in this study as well. Now I want to open it for questions. I can answer any questions that anybody has.